it does in preventing depression. Aripiprazole, the same story. Aripiprazole prevents mania. It does not seem to provide any benefit in preventing depressive relapses. And then we have quetiapine, which has been tested in monotherapy in comparison to placebo and lithium. And this study basically showing that quetiapine group depicted on this slide in green, fewer patients in the quetiapine group had a relapse compared with those that got placebo, which is in gray. And you can also see that lithium, which is in blue, again, fewer patients in the lithium group had a relapse compared with those that got placebo. Now, this is looking at both depressive and manic relapse together. Now, what happens when you look at those separately? So here is the manic relapse for each of the groups. And again, as you can see, quetiapine beat placebo, lithium also beat placebo for prevention of mania, and the hazard rate for quetiapine against placebo was about 0.29. And if you look at the depression recurrence, again, it's the same thing. Both quetiapine and lithium seem to beat placebo in preventing a depressive event. And again, for quetiapine, the hazard ratio was 0.3 as well. So basically, this study is suggesting that both quetiapine and lithium prevent mood episodes, and they're effective in preventing both depressive as well as manic episodes. Now, what about if you give quetiapine in conjunction with lithium or valproate? And that's been tested in 2 large trials, and what you're seeing here are the combined data from those 2 trials. So the top bar, which is the top line, which is in green, is the survival curve for the quetiapine group, and the bottom graph is the survival curve for the group that got a mood stabilizer plus placebo. And as you can see, fewer patients that got quetiapine along with a mood stabilizer had a relapse compared with those that got placebo and mood stabilizer. And the same thing is true for mania. Fewer patients in the combination group had a manic relapse compared with the mood stabilizer monotherapy, and the same is true for depression as well. So again, quetiapine, when given either in monotherapy or in combination with a mood stabilizer, appears to provide benefit in preventing both manic as well as depressive relapses. Risperidone has also been studied in some of the double-blind placebo-controlled trials. There's 1 monotherapy trial that's been finished and 1 combination trial, and in this trial, Consta was given as an adjunct to treatment as usual. And here are the results. So in this particular trial, patients with acute mania, after they had remitted from mania, went into a double-blind phase. And during the double-blind phase, they either got risperidone Consta or a placebo injection. And as you can see, patients that got Consta, depicted here in the green, fewer patients had a relapse compared with those that got saline injection, suggesting that risperidone injection is effective in preventing relapse of mood episodes in bipolar patients. Looking at the number of patients that had relapsed, 29% of patients had a relapse in the Consta arm versus 57% of patients in the placebo group. And similar sort of story with the adjunctive treatment as well. So here, in this particular trial, patients that had frequently relapsing bipolar disorder. So these are the patients that are somewhat similar to rapid cycling patients. Were recruited, they were treated with adjunctive risperidone injection in addition to whatever else they were getting. Those that got stable went into double-blind phase, and in the double-blind phase, half of the patients continued the Consta, other half had a placebo injection. And looking at the relapse rates again, fewer patients that got Consta in addition to the treatment as usual had a relapse compared with those that got the placebo injection. Relapse rates 22% in the Consta group versus 48% in the placebo group. The last study I want to talk about is the ziprasidone study. Again, in this trial, manic patients, after they got better with ziprasidone and a mood stabilizer, went into double-blind phase. And in the double-blind phase, half of the patients got ziprasidone plus mood stabilizer, other half got mood stabilizer plus placebo. And of course, fewer patients in the ziprasidone group had a relapse of a mood episode compared with those that got mood stabilizer plus placebo. adverse events were not significantly different in these two groups. So based on these data, this is what we recommended in terms of our CAN-MAD guidelines. We said in terms of the first line, we said lithium is okay, quetiapine is okay, lamotrigine is fine, but mainly for those with a mild mania, because lamotrigine doesn't prevent mania that well. Valproate is fine, olanzapine is fine, risperidone consta is fine, aripiprazole again works mainly in preventing mania, and of course adjunctive ziprasidone or quetiapine or risperidone based on some of these trials. Psychological treatments have been tested as well, and pretty much all psychological treatments given as adjuncts to pharmacotherapy do seem to reduce the risk of relapse, and it looks like there doesn't seem to be a huge difference between various psychosocial treatments. They all seem to work equally well. So based on that, what can we say in terms of the recommendations for your state? I would say we should add a level 0, and I would suggest that every patient with the bipolar disorder should be offered either psychoeducation or other psychosocial treatments in conjunction with pharmacotherapy, because as we said, there is evidence now suggesting that the psychosocial treatments do seem to provide additional benefit in preventing relapses in bipolar patients. In terms of pharmacotherapy for level 1, you could pretty much leave all the recommendations that you had previously, except that I would add a few more to that. So for example, now we have data for quetiapine monotherapy, so I would add that. Risperidone consta monotherapy, I would add that. Adjunctive ziprasidone or risperidone quetiapine would also be okay. And for preventing depression, again, I would add quetiapine or adjunctive quetiapine because that seems to work. And then for level 2, you had monotherapy with carbamazepine, but you also had monotherapy with quetiapine, risperidone, ziprasidone. And of course, these are now moved to the first-line treatments because we now have the data. The only thing I would add to level 2 is the olanzapine plus fluvoxamine combination, and I would delete the first generation here in the level 2 because there's evidence that the first generations do increase the risk of depressive episodes in bipolar patients. So that's where we're going to stop, and if you have any questions, I'll be happy to answer. Thank you very much for your attention.